Good evening, everyone. I'm delighted to be speaking at the inaugural Fungal Frontiers in the Asia Pacific Education event. I'm Kate Garnham. I'm an infectious diseases physician and microbiologist working on the Gold Coast in Queensland, Australia. Tonight, I'm sharing a case representing several facets of Cryptococcus infection to introduce some of the concepts the fantastic speakers after me will share, courtesy of their considerable knowledge and expertise. Our case tonight is of a 61-year-old woman referred for assessment with a few days of drenching night sweats preceded by a month of headaches with occasional visual disturbance. This was associated with confusion, memory, and behavioural change. Clinically, her general practitioner noted a breast mass and two unusual subcutaneous nodular lesions on her torso. Diagnostic medical imaging demonstrated numerous intracranial ring-enhancing lesions and a solitary right lower lobe pulmonary mass with associated axillary lymphadenopathy. There was also extensive bilateral breast and torso cutaneous and subcutaneous hypodensities. The provisional diagnosis was metastatic malignancy, and a biopsy of the readily accessible subcutaneous lesions was taken. However, the biopsy did not demonstrate malignancy. Rather, there were numerous round encapsulated bodies with halos, which were positive on periodic acid Schiff and Grocot's methenamine silver stain. The images on this slide are not from the patient specimen, but from an online textbook. This is Cryptococcus yeast, with the capsules well demonstrated on gram and mucocamine stain. Given the presentation, a lumbar puncture was performed. There were clear abnormalities, which you see on screen. Importantly, the opening pressure was normal. Cryptococcus gattii was cultured from the cerebrospinal fluid. The patient was screened for any contributory immunodeficiency, which was unremarkable apart from a slight CD19 lineage lymphopenia. The screening included a thorough assessment for malignancy given her presentation, with no malignancy found. Interestingly, flow cytometry of peripheral blood did demonstrate an atypical CD4 T-cell population. This was not a hallmark of any particular diagnosis. The abnormalities persisted over time. It may represent an undefined hematologic susceptibility to Cryptococcus infection, or alternately, may be representative of the patient's immune response to fulminant disseminated cryptococcosis. Antifungal susceptibility testing of Cryptococcus gattii gave the results you see on screen. It's important to acknowledge that there are no clinical breakpoints for Cryptococcus. MIC values can guide therapy according to clinical site of infection and expected drug concentrations. Recently, however, both UCAS and CLSI have mentioned some epidemiologic cutoff values, which I've included for interest, and there's further links at the bottom of the slide if any listener should wish to explore this concept further. The patient commenced appropriate weight-based amphotericin and flucytosine therapy planned for a 6-week induction course. This was complicated by an early drop in creatinine with associated hypokalemia, presumably due to the amphotericin component. Repeat CSF testing on day 20 hearteningly demonstrated a normal opening pressure and yielded no growth. Unfortunately, after 3 weeks of amphotericin therapy, the renal injury worsened despite closely monitored fluid and electrolyte supplementation. A decision was made to change to voriconazole consolidation therapy earlier than intended. The following day, the patient reported a worsening headache with auditory and visual hallucinations. Clinically, her cognition declined. Further lumbar puncture demonstrated newly elevated opening pressure at 30.5 centimetres of water. There was progressive neurologic decline and hydrocephalus despite recommencing amphotericin and flucytosine. This required insertion of an external ventricular drain. Steroid therapy for presumed iris was commenced with dexamethasone 4 milligrams 4 times a day. The EVD remained in for 9 days and the steroids were weaned over a fortnight. The renal injury then reoccurred. Given that 6 weeks of an amphotericin-containing regimen had been administered, voriconazole was recommenced, with therapeutic drug monitoring swiftly within range. After nearly 10 weeks of therapy, there was good neurologic and radiologic recovery, and the patient was discharged after a period of in-hospital rehabilitation. So here we see the extensive perilesional edema characteristic of iris. Progression of the primary infection due to treatment failure is extremely uncommon and was excluded with the 3-week progress lumbar puncture. Immune reconstitution inflammatory syndrome is quite common, with varying degrees of severity in cryptococcosis. It has been reported in up to 44% of patients with Cryptococcus gattii infection. The syndrome is characterised by paradoxical clinical worsening despite appropriate antifungal therapy. It occurs more commonly within the weeks following antifungal commencement, but can occur as late as 12 months following initiation of therapy. It is important to be aware of this syndrome, to recognise early and to exclude treatment failure with repeat sampling. The treatment for iris consists of anti-inflammatory therapy, initially with steroids, and intracranial pressure management, sometimes requiring neurosurgical intervention. Alas, this patient represented after 11 days at home with worsening confusion and gait disturbance. They also had a drug-induced liver injury and new subcutaneous lesions had developed, again demonstrating the encapsulated yeast of Cryptococcus on histopathology, once again culture negative. She was readmitted and a repeat lumbar puncture demonstrated elevated protein of 1300 with near normal white cell count. The opening pressure was moderately elevated to 25 centimetres of water. Culture was negative. An MRI of the brain demonstrated worsening CNS perilesional edema with midline shift and a new right lung lesion. Due to the drug-induced liver injury, the patient was again recommenced on liposomal amphotericin B and flucytosine. After 14 days, voriconazole was reintroduced in a graded manner with swift achievement of therapeutic plasma levels. The liver injury did not reoccur. Due to the worsening CNS edema and neurologic symptoms, dethomexazone 4 milligrams 4 times a day was again commenced with a long wean over several weeks. Shortly after the steroids were weaned, new subcutaneous lesions sprang up, once again culture negative, once again demonstrating encapsulated yeast on biopsy. The confusion and headache also reoccurred. These symptoms were once again steroid responsive. However, despite steroid therapy, new retinal lesions with associated visual change developed. In this context, thalidomide, 100 milligrams daily for 4 weeks was trialled. Thalidomide has been described in case reports of successful second-line therapy for cryptococcal iris. There was a partial unsustained response clinically and radiologically. 2.5 weeks after completion of thalidomide, the neurological symptoms again recurred with radiologic increase in lesion size and perilesional edema. Interferon gamma was trialled for 11 days. Again, a therapy described in case reports of successful second or third line iris treatment. Endogenous interferon gamma production is associated with protection against Cryptococcus disease, leading to increased phagocytosis and fungicidal activity of the phagocytes. The patient was treated with systemic steroids once the course of interferon was complete, with a very gradual wean over many months. Eventually, the patient was discharged following further rehabilitation, but could no longer work. She has occasional recurrence of skin lesions. Radiologically, the lung lesions have resolved, but the breast and CNS lesions are unchanged. She is completely weaned from steroids and continues on oral antifungals. Here we see the large amounts of perilesional edema, which have persisted over many months associated with the patient's symptoms. Overall, we felt this patient had Cryptococcus post-infectious inflammatory response syndrome. This is described in apparently immunocompetent hosts in whom immune reconstitution in the classic sense is unlikely, and the mechanisms discussed below likely contribute to iris in immunocompetent patients as well. So on the same clinical and pathophysiologic spectrum. This is proposed to be a response to fungal antigens released during therapy and with alterations in immunomodulatory pathways. Whilst yet to be fully elucidated, my simplistic take is this. Classical macrophage M1, the inhibit or kill polarization results in T cell Th1 cytokine profile, which is essential for clearing Cryptococcus. This profile includes interferon gamma, which we've mentioned earlier, for its protective importance in Cryptococcus clearance. However, Cryptococcus is known to modulate macrophage polarization from M1 to the M2 heal and immunity polarization, resulting in a T cell Th2 cytokine profile, which does not strongly feature interferon gamma. This is more common in higher burden infections in laboratory murine studies. The Th2 cytokine profile can result in a pathogenic immune response and may result in pathogen persistence. The optimal therapy in cases such as these is an ongoing question. However, a review of 15 patients by a team in Maryland, USA, provided broad definitions and an initial steroid protocol to be tapered to clinical response. The main criteria are persisting or worsening neurologic deficits in patients such as ours, again once microbiologic exclusion of treatment failure is confirmed. Persistent abnormalities of CSF findings and neuroimaging are considered supportive criteria, but as the natural history of these parameters during Cryptococcus treatment is undefined, this criteria is quite subjective. The outcomes of the 15 patients in this small study were quite positive. Nearly all had improvements in neurologic symptoms, radiologic, and CSF parameters. Audiologic improvements were not universal. The authors caution awareness of the safety profile of long-term steroid therapy. Whilst we as infectious diseases physicians are familiar with the infectious risks of immune suppression, we are sometimes less conversant with the metabolic and psychiatric impact of long-term steroids. If in doubt, advice on monitoring should be sought. Finally, flummoxed by the widespread and persistent nature of the patient's primary infection and severe and protracted inflammatory symptoms, we undertook targeted exome sequencing to assess for any undiagnosed immunodeficiency. A heterozygous variant of uncertain significance was noted in the NOD2 gene. NOD2 regulates the NLRP3 inflammasome, a cryptococcal recognizing pathogen recognition receptor, which can be inhibited by encapsulated cryptococcal cells. NLRP3 inflammasome dysregulation has been implicated in abnormal interferon expression and abnormal inflammatory responses. However, the scientific opinion of the testing laboratory is that protein folding and therefore NOD2 function is unlikely to have been impacted by this variant, so this connection is theoretical only. With that, I'll wrap up and hand back to the chair. Thank you very much for your attention.
Okay, thanks. Thanks a lot, Kate. Great case that was. We need to move things along, so I think we can all take questions at the end of all three speakers. May I now invite Julien Coussement, who works at the Peter Mac in Melbourne. Julien, please.
Thank you, Benhok, for your introduction. Hello, everyone. I'm going to share my screen now. Can you see my slide?
Yes.
Wonderful, thank you. So, hi, everyone. I would like to start by thanking the organizers for giving me the opportunity to talk about the changing epidemiology of crypto today. So, my name is Julien Coussement. I was between 2020 and 2022 a lucky and happy ID fellow working at Peter Mac Cancer Centre in Melbourne, Australia, under the supervision of Monica Slavin. So crypto, let me start by saying that crypto was listed by WHO in 2022 as one of its top priority pathogens. But this is, of course, related to the major impact that crypto neuroformance has in patients living with HIV. According to a 2020 global estimate published in The Lancet, there are around 150,000 cases of cryptomeningitis a year and over 100,000 related deaths. As many of you know, the major burden of diseases in Africa. But the picture is very different in resource-rich settings, where first we have relatively easy access to diagnostic and preventive tools for HIV, as well, of course, to now highly effective and relatively well-tolerated antiretrovirals to treat HIV, reducing the risk of developing cryptococcosis and other opportunistic infections. And second, in contrast, crypto infections are increasingly appreciated in patients without HIV, including both apparently immunocompetent patients, but also other immunocompromised patients, including transplant recipients, cancer patients, or patients with autoimmune diseases. And this is with the intention to precisely understand the current epidemiology of crypto infections in Australia and New Zealand in this rapidly changing environment with new forms of immune suppression favoring the emergence of new subgroups of immunocompromised patients that we did the study I will now present to you and which was very recently published in CID. So what we did is a retrospective study across 36 Australian and 10 New Zealand hospitals, which were recruited through the ANZMIG interest group. So to identify eligible cases, we asked participating investigators to systematically screen the micro, histopathology, and medical record information systems. Adults with crypto diagnosed between 2015 and 2019 were included, and crypto was defined using the recent 2020 EORTC MSG definitions and therefore categorized as either proven or probable. This means that we excluded both patients without mycological confirmation of infection, as well as patients who had asymptomatic colonization of the airways only. So let's start with the ratio of HIV positive to HIV negative patients in our recent Australian and New Zealand landscape of crypto. So we identified a total of 475 patients from our 46 hospitals from Australia and New Zealand. And the first surprising finding was the very low ratio of HIV positive to HIV negative patients. In fact, only 10% of the patients who had crypto in our hospitals were patients with HIV. This represented only around 10 patients with HIV per year for all our 46 Australian and New Zealand hospitals. So one could suspect that this very low proportion was related to the fact that we have many crypto gattii cases in Australia, which, as you very well know, typically affect patients without HIV. But no, this very low proportion of around 10% was confirmed across all subgroups, including culture-positive crypto neoformans cases, but also crypto gattii cases or culture-negative cases. This proportion of 10% is also much lower than those observed in previous population-based studies performed in the US or in France, which typically found patients with HIV to explain most cases of cryptococcosis. And this proportion of 10% was also much lower than the proportion of 43% that was observed in a previous population-based study coordinated by Sharon in Australia and New Zealand around 20 years ago. So this low proportion of 10% can probably be explained by factors such as the relatively low prevalence of uncontrolled HIV in our area and the rising number of other compromised patients. Something that we detected quite late following one of the reviewers' comment, but which is interesting, I think, is that while the number of HIV cases remained stable over the 5-year study period, with, as I said earlier, around 10 cases a year, this is the orange line here, the yearly number of HIV negative cases doubled during the study period, from 59 cases in 2015 to 119 cases in 2019. In other words, in our countries, the HIV positive to HIV negative ratio is not only very low, but also continuously decreasing. Let's now focus on the 426 HIV negative patients who had crypto in our study and see exactly who they were. So around 60% of them had a major immunocompromising condition already known when crypto was diagnosed. These immunocompromised patients can be dissected into 3 subcategories of almost equal size. First, around 1/3 of them were cancer patients. Most had a hematological malignancy, typically CLL or non-Hodgkin lymphoma, that represented almost half of cancer-related cases. We had 12 cases that were related to BTK inhibitors. And in contrast, malignancies that are usually seen as being at high risk for invasive fungal diseases were very rare, as illustrated by the fact that none of the patients had AML, that we had only 1 allogenic bone marrow transplant recipient, and that only 2 cases were seen in neutropenic patients. Another third of immunocompromised patients were solid organ transplant recipients. Most of them were kidney transplant recipients, followed by lung and liver transplant recipients. Some important findings I would like to share with you today are that first, crypto typically occurred late post-transplant. So even if early cases are sometimes seen, typically in the setting of donor-derived infection, most occur late. And second, only around 15% of the transplant recipients had a recent history of rejection, which is, however, typically seen by clinicians as an important risk factor for very opportunistic infections such as crypto. The remaining third were patients with a major immunocompromising condition other than cancer or organ transplantation. Most of them had a systemic inflammatory disease, with the most common condition being rheumatoid arthritis, RA, which was present in 22 patients. Less common inflammatory diseases included vasculitis, sarcoidosis, or inflammatory bowel disease. Most patients were on steroids for the immunocompromising condition, and a large part of them also received additional immunosuppressive agents. One emerging risk group I would like to highlight today are multiple sclerosis patients receiving fungal IMOD, also called Gilenya. We had 9 patients in this situation, confirming previous case reports and very small case series. For those who are not familiar with this drug, fungal IMOD is a recent oral immunomodulating agent which sequesters lymphocytes in lymph nodes, preventing them from contributing to the immune reaction. The remaining patients who we considered as immunocompetent were either truly healthy when crypto occurred, or sometimes patients with medical disorders such as lung disease, liver disease, kidney disease, or diabetes that may possibly have predisposed them to crypto. But the role of these comorbidities remains unclear, and some of these patients might, of course, have immune defects that remain unrecognized, such as, for instance, anti-GM-CSF antibodies. This group of immunocompetent patients had specificities. I won't go into the details here because this is something that Sharon Chen will discuss in the following presentation, but as expected, the absence of an immunocompromising condition was significantly associated with crypto gattii compared with crypto neoformans infection. After these slides on patient groups, I would like to talk about how HIV negative crypto presented in our study. So first, we observed CNS involvement in less than 50% of patients without HIV. This obviously contrasts with the situation in patients with HIV, who, as you very well know, very often present with crypto meningitis. CNS involvement was seen in around 40% of immunocompromised patients, who instead quite often had isolated pulmonary infection. In immunocompetent patients, CNS involvement was more common, driven by patients with crypto gattii infection, as we will discuss later. Now, let me share with you 4 other key messages for clinicians, which I was not well aware of when I started the study. First, 1/6 of the HIV negative patients who had crypto in our cohort were asymptomatic at time of diagnosis. That's quite a lot. In these patients, crypto was typically an incidental finding on chest imaging, for instance, in cancer patients, having follow-up imaging for the cancer, or in trauma patients. Second, classical indicators of infections such as fever or increased CRP were very often absent in 75% and 45% of the cases respectively. The possible normality of CRP is obviously something that we know well for patients with bacterial infections due to low virulence organisms, such as, for instance, prosthetic joint infections due to coagnate staph, for instance. But these unremarkable levels of CRP are in contrast with other invasive bacterial and fungal diseases, as well as with patients who have both HIV infection and crypto infection. Third, serum crypto antigen, CRAG, which, as you know, is positive in over 99% of HIV positive patients who have crypto meningitis, was positive in only 85% of the patients without HIV that were tested in our study. Consequently, it's important to remember that neither the absence of symptoms nor a normal CRP or a negative serum CRAG could be used to completely rule out crypto infection in patients without HIV who have compatible lesions. Last, another pitfall recently described and confirmed in our cohort is falsely negative results with the BioFire FilmArray panel in some patients who had true cryptococcal meningitis. Our study findings may also be used to inform the debate regarding the commonly made recommendation to routinely perform a lumbar puncture in HIV negative patients with crypto, even when there are no neurological symptoms suggesting CNS involvement. So among the 167 patients without HIV who had a systematic lumbar puncture done to screen for asymptomatic cryptomeningitis, the positivity rate was only 13%. So even if we obviously do not want to miss asymptomatic meningitis, which is very well described with crypto and which is a very important information for clinicians, on the other side, over 85% of lumbar punctures in our patients without neurological symptoms were normal. And interestingly, we found that having a high serum crack titer or Cryptococcus bloodstream infection predicted well the risk of asymptomatic meningitis in our patients without HIV. Specifically, at least one of these two blood biomarkers, so high crack titer and positive blood cultures, was present in 95% of the evaluable patients found to have asymptomatic meningitis. So previous studies have already looked at that. They've evaluated the potential of usefulness of serum crack titer and blood cultures to reduce the number of systematic LPs in patients without HIV. But these studies typically recruited very few patients who had asymptomatic CNS involvement or included only very limited information baseline neurological status. Even if our study provides another brick in the wall here, additional studies are obviously needed to determine whether serum crack and blood cultures can safely be used to confine the use of LP to the asymptomatic patients who are the most likely to benefit. So before I conclude, just a few words on the management outcomes of HIV negative patients with crypto. I won't say too many things as this will be the subject of our second paper, which we are currently preparing, but one thing we already analyzed is the risk of death. 1 year survival status, that's on the right, was available for almost all study patients. And 1 year all-cause mortality was around 21% in both patients with HIV and patients without HIV in our study. Two things we can say about these Kaplan-Meier survival curves on the left, which are for the patients without HIV, are that first, as you can see, most deaths occurred quite early after diagnosis with a 10-week all-cause mortality of 12%, and that there were significant differences between subgroup of patients without HIV. For instance, mortality was highest among cancer patients, around 34% at 1 year, and lowest among patients with gattii infection, with a mortality around 11%. And I think we all agree to say that even if the mortality we had in our cohort, so 12% at 10 weeks and 21% at 1 year, is much lower than what is seen in HIV-associated cryptomeningitis in resource-limited settings, where 10-week mortality is typically 2 to 4 times higher than what we saw in our study. It is still unacceptably high. To close the loop, let's go back to my first slides, where we saw that in our countries, in Australia and New Zealand, 90% of infections occur in patients without HIV. Well, this means that because there are no clinical trials focusing on patients without HIV, but many very high quality randomized controlled trials done in patients with HIV, we here find ourselves managing 90% of patients using evidence from trials done in the remaining 10% of patients. So I think we will all agree to say that there's a critical need for trials in patients without HIV. So it's time to conclude now. So we have seen that HIV explains only 10% of all recent cases of crypto in Australia and New Zealand. As shown earlier, patients without HIV are a very heterogeneous group of patients. A big half of them are immunocompromised patients. And among them, recently emerging subgroups include cancer patients on BTK inhibitors or multiple sclerosis patients on fingolimod. Among patients labeled as immunocompetent, cryptogattii was, of course, particularly frequent. It's possible that a significant proportion of these so-called immunocompetent patients are not truly healthy and have an unrecognized deficit. We then talked about the clinical specificities related to HIV-negative crypto infection. So first, CNS involvement was much less common than it is in patients with HIV infection, except for cryptogattii infection, which will be covered by Sharon in a minute. Second, I hope I convinced you that neither the absence of symptoms nor a normal CRP or a negative serum crack could be used to completely rule out crypto in HIV-negative patients. And last, over 85% of the systematic LPs that were done in our patients without neurological symptoms were normal. And having a high serum crack titer or fungemia predicted well the risk of asymptomatic meningitis. So as I said, even if our study provides another brick in the wall, more studies are obviously needed to determine whether serum crack and blood cultures can safely be used to confine the use of LP to the patients who are the most likely to benefit from them. And we finish with the unacceptably high mortality associated with crypto in our patients without HIV infection, and surely agree on the urgent need for randomized controlled trials focusing specifically on this group of patients. Thank you again for giving me the opportunity to talk today, and many thanks to all study investigators and participants, including, of course, my two wonderful supervisors, Monica Slavin from Melbourne and Sharon Chen from Sydney. We will now talk about cryptogattii.
Hello, we'd like to now introduce Sharon Chen. I don't think Sharon needs much introduction. She's a professor of infectious diseases from Westmead Hospital in Sydney and at the University of Sydney as well. And she's going to talk about Cryptococcus gattii, particular aspects of it. So please, Sharon, take it away.
Thank you, Orla, for that kind introduction, and thanks to Helen for waving the magic wand, although in some respects it might have been better if I were kept in the dark, but it is what it is. So thanks everyone for joining the webinar. And this was a little bit of an experiment, and not just in its inception and the logistics, but also to test the audiovisual capacities of ASID and indeed the AFWG. So I'm glad it's lived up to its name so far. And I've entitled my talk Cryptococcus gattii and Cryptococcus neoformans, and borrowed a clause from Shakespeare, whereto tends all, and all be reviewed. I'm an ID physician at Westmead Hospital in Sydney and also a clinical microbiologist, and it's really good to be with all of you tonight. These are my disclosures, a few grants, ad board meetings, and speakers' fees. So where to? In Shakespearean language, it literally means to what place or end. And why do we bother about distinguishing between C. gattii and C. neoformans? It's an exercise in itself that I hope you will enjoy. What I thought I'll do tonight is to give a brief historical perspective, then the global perspective, and then the Aussie, New Zealand, Asia Pacific perspective. Julien's already touched on his study. And then to provide some context around management guidelines for C. gattii, but acknowledging that this is very much the tip of the iceberg. The first descriptions of cryptococcosis date back to 1894. For C. neoformans, it was described in a patient with tibial osteomyelitis, but we had to wait until 1970 to wait for the first descriptions of C. gattii, although an atypical strain of C. neoformans was noted in the same year that C. neoformans was described. And you can all read the details of the original publication, authored by Gattii himself and his colleague Eccles, and published in 1970. Much experience has been gained since, and we know a lot more about the clinical aspects in humans, in koalas, in other animals, and indeed in the environment. which brings me to the ecology and the natural habitat of Cryptococcus gattii. To this, we attribute a lot of the work to Professor David Ellis. You can see him here. This was way back in the early 1980s, and Tanya Pfeiffer, when they went about sampling eucalyptus material and trees for the presence of Cryptococcus gattii. And here's one tree that David frequently visited to obtain gattii isolates from. And his publications are many. I've just listed two here to read, you know, makes nice bedtime reading. We know that you can find gattii in eucalyptus material in the species Cameldulensis, terraticornis, rudis, and others. And interestingly, all the molecular serotypes associated with eucalyptus trees in Australia are VG1. Now we know that gattii infections have occurred overseas, in Canada, in the US Pacific Northwest. It's been associated with varied vegetation. And interestingly, these molecular types have been VG2 and VG3. So there are definite geographic variations. There are other many giants of Cryptococcus gattii, at least in our region. And one of these is Professor Tanya Sorrell, who has done a lot of work on the pathogenesis, and many aspects of the work can be found in the publication in 2014 in a review. But there are others, and short of fearing to omit some of them, I've just listed all my colleagues here in red. And although I've listed the ANZMIG colleagues and the AFWG colleagues last, they are certainly not the least and have done very, very good work on descriptions of various aspects of gattii. So does it matter whether we distinguish C. neoformans from C. gattii? Well, there are three key questions. Does it matter clinically? We know there are already epidemiological difference. Does it impact on therapy? And is there a differential outcome between neoformans and gattii? This slide is well known to many of you, looking at some of the differences between neoformans and gattii. Where they occur, well, C. neoformans is common and the burden is well described. C. gattii is more uncommon, but the burden is becoming more certain with more studies. C. neoformans occurs worldwide, and C. gattii was thought to occur in tropical areas, but it's certainly moved beyond this. The risk factors for neoformans are associated with HIV infection and organ transplantation, and the risk factors for C. gattii are partially defined, and it's difficult because most cases occur sporadically and it's more uncommon, but they do occur in clusters, and this has enabled case control studies. Clinical features, largely meningitis, largely CNS infection and lung infection in gattii. We'll come to that. Diagnosis is not difficult. This is one of the few areas where you can still culture the organism. Screening is appropriate for C. neoformans, but there's no screening or no evidence that screening helps with early detection of C. gattii infection. With regards to antifungal treatment, we know how to treat C. neoformans well, at least in the HIV population. There are clinical trials, the animal models, tells you what to do. With C. gattii, we rely on expert opinion, like around the table here, and to look at case series. This is an old study, and I know this was done in the 2000s, and we've now moved on, but it looks at 4 groups of infection: CNS mass lesions, lung mass lesions, meningitis, and hydrocephalus. And it's broken down into 4 sort of risk groups, if you like. I know that C. gattii is not a risk group, but it stands on its own, but let's pretend it's one for now. And then we have normal hosts, non-AIDS immunocompromised hosts, and HIV patients. And you can see for at least CNS mass lesions, C. gattii wins by far in its association with normal hosts, and it declines with increasing immune suppression. The same for lung mass lesions. Meningitis is a feature for all these host risk groups, and in hydrocephalus, the trend follows the CNS mass lesions, the chest X-ray mass lesions. And here are two examples of what you might see in a gattii patient. And in our study in Australia and New Zealand, we found that mass lesions actually occurred quite frequently in those percentages that I've listed there. Okay, let's look at a more contemporary study, and this is the global perspective, or the US MSG07 study, which is a multi-center study. It's a retrospective study of combined data sets. So going back into the 1990s, but moving into the 2013s or so, it's being conducted in the States, in Canada, and at Westmead in Sydney. And it only included culture-proven cases. So I acknowledge that case ascertainment may be incomplete in this circumstance. These are some of the key findings. So over 400 Neoformans cases, and certainly a large number of C. gattii cases as well. And looking at the location, you can see that the C. Neoformans cases largely stems from Duke and UAB at Alabama, because that's what they see there. The gattii cases were largely from British Columbia from the outbreak, from the US Pacific Northwest from the outbreak, and we worked very hard to contribute 67 cases over that time period. In terms of one of the more interesting findings, time of symptoms to diagnosis, there was a clear difference, which was statistically significant, in that C. neoformans took about 52.2 days to present, as opposed to 36 days. So patients happened to be sicker for longer before presenting for clinical care. Other key findings, and here we have, looking at the clinical features that might corroborate the earlier findings of the Australian study. Lung infection was more frequent in C. gattii, but CNS infection, so all CNS infection, meningitis and brain, was more common in C. neoformans. So it was a little bit of a surprise. Blood and disseminated disease was more common in neoformans, and that's what you would expect. What was also a surprise is that was an association between non-hematologic cancers with C. gattii and chronic lung disease with C. gattii. And this is attributed to a lot of the people that were smokers in the Vancouver Island and US Pacific North outbreaks. So the risks depend on whether it's a sporadic case situation or an outbreak situation. And you just got to know your local epi to make conclusions. This is the last slide on some key findings. So headache was associated with gattii, brain but not lung mass lesions with gattii. So we expected this, and iris that Katherine has so elegantly already discussed. But what was surprising was that the abnormal mental status and neurologic symptoms were not more common in C. gattii. This surprised me, at least. Going to the death rates, 12-month mortality, we look at neoformans, 28%, 26%, with lesser mortality in the gattii group, with an overall mortality of about a quarter at 12 months. But we know that mortality is influenced by host risks. And if you look at these Kaplan-Meier survivor curves, you find that certainly on the right-hand side, here's the overall survival curve with time, with C. gattii 86 patients, and you can see that a slow decline. But if you break this up according to underlying immune compromise, the percentage of patients alive at a week or X weeks after diagnosis is clearly less for the immunocompromised group. And mortality also varied between where you are. So in Australia was 13%, in British Columbia was 8.7%. And I presume was this because this was a community outbreak and patients were largely immunocompetent. Whereas in the US Pacific Northwest, mortality was 33%, where a lot of these patients were admitted to hospital and had underlying comorbidities. Moving on to an even more contemporary study, and this is Julien's study, within the subset of HIV-negative patients, the host risks with respect to neoformans and gattii held true. C. gattii associations, lung, but also CNS. So this was different from the multi-site center study performed in the United States. This time, neurologic symptoms, headache, and meningism were also associated with gattii. Conversely, the time of symptoms to diagnosis was similar between neoformans and gattii. There wasn't a predilection for gattii patients to present later. What about the laboratory and imaging findings? Interestingly, and I think this is interesting, that proven disease, so all histopositive disease, serum Crag tests, CSFs with polymorphs or lymphocytes in them were more likely in C. gattii infection, with an overall increased yield of positive cultures, brain cryptococcomas, and lung nodules. So it certainly, I learned a lot from this study as well. Julien's touched on mortality, and here we have mortality about 21%, with most deaths occurring early, with a 10-week mortality estimated at 12.2%. We looked at host risks in the previous studies, and indeed, mortality was highest in cancer patients, so 31%, and the mortality was lowest in C. gattii infection, so 11.1%. So although patients may be sicker and present with large burdens of fungi, the mortality is lower in C. gattii infection, and this was also borne out in the US study. In the last section of this webinar, before the discussion, I thought I'd just briefly touch upon the principles of antifungal therapy in cryptococcal meningitis. And we are blessed with this fungal infection that we're actually told what to do. It's much more systematic than treating invasive aspergillosis or mucormycosis. We have 4 phases: induction, consolidation, maintenance, and eradication for C. gattii. Any patient with C. gattii, provided the underlying immune compromise can be controlled, if they are immune compromised, should be able to be cured. It's not like the HIV patient. Induction therapy is very well explained by studies in HIV patients, and all contemporary studies focus here. This is a whole talk in itself, and I won't be saying much more, except that you can play around with your agents, you can play around with the doses of the agents, you can play around with dosing regimens, use them once a week, use them once a day. You make it work for your cohort. And basically, induction is about 2 weeks, historical reasons, but maybe not so for gattii. Consolidation, about 8 weeks, maintenance or secondary prophylaxis, and finally eradication. And it's all predicated by these studies that were done many, many years ago in HIV patients. And this is kind of chart that one remembers, so that when you are rung up at 2 a.m. in the morning, you let the ED resident know that you need amphotericin deoxycholate at this dose, with 5-FC at this dose, and they're very impressed that you can remember doses at that time of the day. So induction therapy, amphotericin deoxycholate and 5-FC. If there's renal dysfunction, liposomal amphotericin. If 5-FC is not available, then amphotericin as above. And the durations of therapy are shown then. In Australia, we use liposomal amphotericin at that dose and 5-flucytosine, with a strong recommendation backed up by randomized controlled trials. Consolidation and maintenance therapy is more straightforward with an azole. If you can't use fluconazole, think about an alternate azole. And these are for HIV patients. But can we use them for non-HIV patients, as Julien has touched on, and can we use them for gattii? With gattii, there are no prospective treatment RCTs or studies. There are, however, heaps of guidelines: the American guidelines, the Australian guidelines, the European guidelines. In brief, prolonged induction is recommended. So in Australia, we would use induction therapy for 4 to 6 weeks. The IDSA and ECM recommend a shorter period of induction therapy. Consolidation and maintenance in Australia, 12 to 18 months. Sounds like a long time. versus a shorter time in the IDSA guidelines. For CNS and disseminated disease, and this is a strong recommendation that fluconazole monotherapy be not recommended, at least in the initial stages. And there are good reasons for this that I don't have time to go into tonight. Now, why this prolonged course? In the study, performed in the 2000s of 86 C. gattii patients, and admittedly, this is not a large number of gattii patients, the bar chart shows a treatment response stratified by complete response, partial response, stable disease, and progressive disease or deaths by time in months. And you can see that at the 12th month mark, many patients would still improve. And if you stop treatment here, you would be probably shortchanging these patients over here. So many Australian physicians would prefer to treat C. gattii infection for 18 to 12 months. And I know from anecdotal experience that some have treated their patients for far longer than that. And this approach has enabled patients to be cured. In the study of the 86 patients taking this approach, there were no relapses and there was eradication of infection. Now, clinical cure is said to precede radiological cure, but it's very difficult to prove this when, in a retrospective study at least, when you can't control the frequency or the intensity or the type of imaging that may be performed. And now we have newer imaging techniques such as PET scans. Can they help? Park that thought for now. What about lung disease? Now, this is the vexed issue. Looking at all patients, so all comers, and we're not just talking about gattii, because this is a question that many of us get asked about. It all depends on whether you have severe disease or mild disease. And then you will ask, what is mild disease? Well, one approach would be to qualify mild disease as mildly symptomatic, asymptomatic, having no cryptococcomas or cryptococcomas that are less than 2 centimeters. If there's mild disease, then there is some evidence, although it's not strongly recommended, that you can use fluconazole upfront, say daily for 6 to 12 months. Consider a shorter course if the patient is immunocompetent. For severe disease, you treat like CNS disease, regardless of whether they're cryptococcomas or not. And this involves giving an amphotericin formulation and 5-flucytosine for 2 weeks, maybe, or for longer if there are multiple and large cryptococcomas. Then go on to fluconazole, consolidation and maintenance. Another question that we often get asked as ID physicians is, how do you monitor the patient with C. gattii infection? Typically, we would do a LP at 2 weeks. This is in CNS disease, because in C. gattii infection, you can expect a positivity rate. That means growing the cryptococci in about 23% of patients. That's a quarter. That's quite high. It's not an indicator of mortality or progression of disease determinant, but it does influence the duration of induction therapy. And that is why we use a longer course of induction therapy. And you do it once more, at least once, to document mycological eradication, more often if clinically indicated, and to time your end of induction therapy. Imaging, CT, MRI to monitor response, not just to monitor response, but to diagnose new lesions, because you might hit iris, and you certainly want to see that things are improving before you cease induction therapy. And then perhaps at 6 months, or as clinically indicated. And iris, which Kate has gone into, consider if there's a so-called relapse, 4 to 6 weeks plus, but mainly 4 to 6 months. And it's a profile of whether you see brain lesions, whether meningitis gets worse, whether the patient develops new neurological signs, and so on and so forth. And sometimes, they can be thoracic signs, particularly in lung disease. You might get lymph node enlargement. You might get even lymph node enlargement of the cervical chain. So my concluding thoughts are that the management of cryptococcosis in non-HIV patients is challenging, both for neoformans and both for gattii, and it's a real problem when they develop repeat episodes of iris. Know your host risks, know the severity of infection, and know your site of infection, because this influences your treatment strategy. Can results of trials in HIV patients be applied to non-HIV patients? Do not know the answer to that, but that's certainly one that we need to find out. And more research needs to be performed on complications, on iris, on hydrocephalus, and on raised intracranial pressure, none of which we have dealt with tonight. And hopefully there'll be some discussion when we open it up. But before I go, I'd like to thank ANZMIG, particularly Helen, Lara, Alison, for their patience and painstaking work on enabling tonight, and also Robert Broad from the AFWG, and to Ban Hock and his colleagues for agreeing to initiate these sets of webinars with us. We aim to have these 4 times a year. I know that might sound a bit ambitious, but I think if we do it any less, it would probably defeat the purpose. I'd like to thank Kate and Julien for allowing me to twist their arms to present tonight, the co-chairs for chairing the session, and to all of you in the audience. And finally, to Van Tan in Vietnam, and Justin Beardsley for designing the flyers and for helping me promote the meeting. Thank you very much. So I will stop there and hand it back over to Orla and Ban Hock.
Thank you, Sharon, for a great talk. Thank you to all 3 speakers. I think they all had wonderful presentations. I'm sure everyone has learned a lot. It's time for some questions. There's one in the chat, and I think this relates to the apparently immunocompetent who are found to have cryptococcosis. So other than HIV testing, are there tests that we should do? What immune deficiencies should we look for? Maybe.
Well, look, I can start because I'm the most junior, so then people can fill in the gap for me. So I think we've all seen these patients, haven't we? People who appear to be completely normal and then often have some sort of hitherto undiagnosed and quite subtle immune deficit. And probably the commonest ones that are reported in the global literature would be an idiopathic T-cell deficiency, particularly of a CD4 lineage. Other T-cell abnormalities, there's some work globally that suggests some B-cell abnormalities, in particular memory B-cell deficiencies may be associated. Of course, we know the classic anti-GM CSF antibodies associated with Cryptococcus gattii and also with pulmonary alveolar proteinosis, which is itself a risk for Cryptococcus infection and disseminated nocardiosis. I think I listed quite a few things there that we did, and some of those were scraping the bottom of the barrel just to find out why this patient, we were really worried that she had a malignancy. So we were sort of running through everything that we could think of with all those lumpy lesions. But I don't know if you have to routinely look for things like multiple myeloma. Sarcoid, other autoimmune and malignant conditions can also be associated with cryptococcosis.
You got anything to add?
I'm trying to raise my hand. Raise my hand?
Well, yeah, go ahead.
It's raised, so go ahead.
Okay, I should be good at this after 3 years of Zoom and Teams meetings. Kate's absolutely right. We would routinely screen for CD4 lymphopenia because we found in our earlier study that a not insignificant number had CD4 lymphopenia, but also IgG subclass deficiencies, which has been described. So I think Kate's covered it very nicely, but they're the 2 that we would screen, and also for the anti-GM CSF antibodies.
Can I ask a question related to that? Would you only screen the patients that present with the most severe presentations, like for instance, only the patients with CNS, crypto gattii infection, or would you screen more largely? Because we've got I think it was 1 or 2 years ago in CID, a paper from Asia, which showed that even in some cases that we would have considered not too severe, like just simple lung infections that sometimes did not even require hospital admission, sometimes these patients were found to be positive for anti-GM-CSF antibodies. I guess the question is also what we're doing with this potentially positive result, but I'd be interested to know your thoughts about that.
Banhock and Ola? Oh,
sorry, I didn't get his drift. Can you say that again?
Yes, sorry, we're looking at trying to answer the questions as well at the same time. Yes, can you please repeat?
Yeah, sure. So my question was about not only how to screen and what tests to order, but more about the population that we would like to screen for unrecognized deficits. So my understanding is that in the past, we've been screening mainly patients with particularly unexpected and severe presentations, but there was a paper in CID from Asia, maybe 1 or 2 years ago, which showed that sometimes in patients with some relatively mild presentations, like just a simple lung gattii infection, you sometimes find anti-GM-CSF antibodies in these patients. So I wanted to have your thoughts about the right population to screen and the potential benefits of screening this patient with, of course, the question of what do we do if the search for autoantibodies come back positive.
Mm-hmm.
Although why don't you
answer? Okay, I'll give an answer. I don't that there's certainly no real data in the literature as to what to do in this setting, but I certainly would I personally would be in my clinical practice would investigate everybody, and perhaps the rationale behind that is it might well affect your duration of treatment. It might indicate whether you give secondary prophylaxis or not. It might indicate how long you monitor them for and whether you think about other infections that they might actually end up getting as well, like other opportunistic infections as well. So I think for me, sort of just say, oh, they've got Cryptococcus gattii, the immunocompetent or apparently immunocompetent is probably not enough. So that would be what I would do clinically as far as I'm concerned. And what was the second part of the question again? Sorry.
No, that was it. I think you perfectly answered.
Yeah,
thanks.
Okay, thank
it's
you.
Interesting
Sorry.
to know your what.
Yeah, I was. I've just come back from overseas, so I'm a bit jet lagged. So I'm still not computing everything. But yes, yeah, that would be my rationale behind investigating everybody. But I do think, as Kate has quite well pointed out, we probably need to start, and Tori Hall as well as put in the question, we probably need to start thinking about what are the type of investigations we should do, what sort of battery of investigation should we do in these apparently immunocompetent patients, and also probably start thinking about storing samples, particularly for genomic analysis going forward. I mean, sometimes we might have done that on an ad hoc basis in the past, and that might be a good thing for us to think about going back to see our immunocompetent patients. Any of them got stored samples that we could think about doing genomic analysis that we couldn't do before, but we now actually can. And that might help us to fill in some gaps and indicate what we do going forward.
Thanks, Ola.
Yeah.
Although that invites entering a minefield, an ethical minefield.
we are, but sort of it's the other side of the coin is, we don't want, sort of provides information for people going forward as well in the future, and also for monitoring these patients and preventing relapses going forward as well.
I think one group that, thanks, Ola, and I agree with you. And one group that we are not relatively ignoring, but probably don't think about enough is children. I've seen quite a few very severe non-CNS cases in children, and for some reason, maybe it's a skewed population, they all have come back with auto-GM-CSF antibodies and some kind of immune deficiency. Pediatricians are, they're more in tune than a lot of adult physicians in investigating for immune deficiency because there are registers of this and that. But it's interesting that in children, it seems to be a slightly different population, and I think we need to have more attention to them.
Okay, maybe we go on to another topic. This one, I think, is for Sharon from Piotr Klebitsky, my colleague. If the morbidity of Cryptococcus gattii is driven by iris and abnormal immune responses, why is extending antifungal therapy the most common recommendation?
That is a good question. I mean, iris certainly drives morbidity, but morbidity is also influenced by the presenting symptoms. So if you have severe presenting symptoms in terms of neurology, in terms of cranial nerve palsies, these things tend to take some time to get better. And even in lung infection, if you have a large lesion, and even if there are few symptoms at presentation, you can actually get sicker as time goes on, and you need that longer period of time for the lesion to shrink. It's very difficult to stop treatment if the patient's still complaining, not back to where they were, can't think properly, got headaches, and have a whopping lesion in their lung or their brain. It's really difficult to stop treatment. I know I'm stating the obvious, but that's the reason why we go for longer periods.
Okay, thanks, Karen. I think if many of us would hesitate to stop too early, especially if symptoms are ongoing. And I suppose many people worry that that thing is still alive, although I know that it's ongoing antigenic stimulation by itself can trigger immune responses. But I agree with you that at the moment, until we really know, we probably are erring on the side of caution. A question of the role of isavuconazole. I think Kate's team, I think, used some voriconazole at various points in time when the patient developed renal problems with embysome. This attendee would like us to discuss the role of isavuconazole. Does anybody want to take that?
Well, look, I can tell you, so the whole patient history doesn't fit into a slideshow. So be grateful that I didn't subject you to that. But I think isavuconazole was trialled for a short period. However, the CNS penetrance, whilst there has been clinical success in trials treating CNS invasive fungal diseases with isavuconazole, the CNS penetrance is not considered to be particularly high. And this patient wasn't observed to thrive on isavuconazole. But look, the reason I chose this case is because it was a really hard one and it sort of presents every aspect. So this is not a typical case at all. Really just to introduce all of those concepts so that you could turn them over in your mind as the experts gave you information. So I think overall you probably could use isavuconazole in a difficult case if you wanted to.
I don't know, Sharon. I worry because Vori, there are quite a few papers. I'm not quite sure about isavu, but
so I have not used isavuconazole. I'm not sure if Ola has or anyone in the panel or the audience has. There are occasions that you can't use fluconazole, and for some reason, women. I've had a cohort of women that have lost their hair. Now, losing hair is, whilst it's not, having bad LFTs or, having, it still has a major effect on their psyche. And in those circumstances, you're forced to think of another azole, and you've got a choice. You've got itraconazole. Some people say it doesn't work as well as fluconazole, but you can try it. There is Vori, and I have used Vori with good results, even in gattii. Voriconazole is a good it's a good drug, but it's a poor medication because there are side effects, and to get levels up, you can run into trouble. And then there's posaconazole. So I've tended to use either VORI or POSA have not really used isavuconazole. And it all depends on whether you've got CNS infection or not.
Although you have any points of view here?
I haven't used isavuconazole for cryptococcal disease.
Neither
have used it for other non-cryptococcal infections, particularly Aspergillus, and obviously Mucor as well. But I think it's sort of something that we could potentially use. I think we'll probably see more cases treated with it going forward.
I guess one trap, sorry, Ben Hock, I don't mean to be hogging the conversation, is that a question that I get asked is that the voriconazole MIC is lower and the posaconazole MIC is lower, and you have your fluconazole, which has a MIC of 8. You know, what do you do? You have to bear in mind that these MICs are not comparable, and you need to know the natural distribution of the MICs before you can say that one azole is likely to be more active than the other, because they are not comparable, and you can't compare an MIC of flu of 8 with an MIC of 0.25 of voriconazole. They're not comparable.
Yes, and you cannot look at, that's not the way to look at that. Yes. There's a very interesting question from Niti, from Bangkok. I think this relates to a specific syndrome, the anti-GM-CSF autoantibody syndrome. His question is, how long do we need to treat these patients?
I'm happy for you to have a go, Ben Hock.
Well, my answer is that I don't know, and I don't think there's any study that has specifically looked at just this particular subset and how long in particular. I would go longer. I would go according to the clinical symptoms and manifestations. I would do a lot of things, make sure I take cultures along the way, image them regularly, see them frequently. If I'm using VORI, I take good levels and induce them longer than usual, I think, until I'm comfortable that they're well. And then, go down to maintenance, keep it going. And sometimes I think end up maybe treating radiology, but we do go for 1 year or even a bit more. But although I must say, I don't have experience here. Definitely no series to talk about.
Yes, I don't think there's any hard data either, and you treat until the patient is better and until you're satisfied with a radiological response. The person that I treated the longest, it was a young Aboriginal gattii girl who had pan-bronchial cryptococcosis, no CNS disease, and she remained on treatment for years. She had auto-GM-CSF antibodies, but she remained on treatment for years because we had to make sure that the lesion didn't come back and cause her to go into respiratory failure again. But that's n equals 1, and n equals certainly less than 5.
Yes. Julien, there's a question for you. There was only 85%. Yeah. Can you just take that?
Yeah, could I just briefly comment on the previous question, which was about the
yes.
the use of azoles other than fluconazole, because I just wanted to add something based on the data we are currently analyzing for our second paper, which will be on the management and outcomes of crypto infection in Australia and New Zealand. So in our setting, we had very few patients who received azoles other than fluconazole. We had a few patients who got them, for instance, because they had a co-infection, which obviously was a good indication to get VORI or something else like Aspergillus infection. But Others generally receive them, VORI, POSA, mainly based on MICs, because my understanding is that the treating physician was afraid of not being successful with fluconazole. But something that's interesting is that we had 426 patients. The vast majority of the patients received fluconazole. And when the patients we presented, just as in clinical case, none of them in our big cohort had true clinical failure. I mean, none of them had positive culture again. So my impression is that I don't know what the mix of these, what the MIC of these isolates were. It's likely because we did not look at that in our retrospective study, and it's possible that some of them had a high MIC, but most people received fluconazole and apparently did very well using what we do in Australia, which is prolonged induction therapy and effective consolidation and maintenance. So just a comment which I think goes against the systematic use of VORI, for instance, when the MIC is raised.
Good, thank you very much for clarifying. Maybe you want to take the question directed at you from Dr. Blake Neild. Only 85%, I think, were ordered by CRAG, were diagnosed by CRAG. So, and if you had to rely on histopath, how did you distinguish between neoformans and gattii? I think that's the thrust of his question.
So I'll probably, I'm not sure I can understand the second part of the question, but definitely the 15. The remaining 15% were generally diagnosed based on culture only. This included mainly patients with lung crypto only, were negative serum CRAG, or sometimes we were not tested. We also had some patients who, that were managed by RESP physicians and who did not get a serum CRAG done, obviously. But it was mainly patients with histopath only. So for these patients who have typically a positive biopsy suggesting crypto infection, it's very hard to determine whether this is crypto neoformans of crypto gattii. Of course, I'd be happy to let maybe Sharon comment on the molecular biology tools, but obviously the clinical presentation and the characteristic of the patients are very important, whether this is an immunocompromised patient, such as a transplant recipient, or not. And I guess it's obviously way more likely to be crypto gattii when the patient is apparently healthy.
Thanks, Julien. So I agree with you, and thanks, Blake, for your question. So I know the vets have clever monoclonal antibodies that can distinguish gattii from neoformans, and I'm not sure if Mark Krockenberger still does this at Sydney University, but you can try a pan-fungal PCR, and if you sequence the whole ITS region, you should be able to tell. Katrina Halliday has also developed a gattii versus neoforman specific PCR based on a different gene that can distinguish between the two species. So yes, we can tell if you're desperate to know. If you see fungal hyphae in your specimen, you can certainly have a go at doing molecular tests. Does that help, Blake? I hope so. I'm not sure if I think, your question.
I think he's trying to just ask what methods we use to. Yeah. Okay, thanks. He said yes, thank you. So I think we have almost. Okay, there are many people asking for a recording, is it? So maybe we will be able to make a we did record, right? So I think we can consider this. I think AFWG and ANZMIG will consider making the recording available. Yes.
Yes.
So I think it's almost 7 o'clock here, which is.
There's one question on therapeutic lumbar puncture that we.
Oh yes, yes.
That I think would be useful to. I could be throwing myself under a bus here, but I think it's probably worthwhile us having a discussion around it about therapeutic lumbar puncture in non-HIV patients with cryptococcal meningitis. Should we manage it as we would for HIV patients?
Oh, I think the LPs are recommended, right? So if you actually find that the opening pressure is high, I think if the patients continue to have symptoms, then whether HIV or not, we should be should be doing that, right? Regular, frequent LPs are recommended in the guidelines. I suppose the question is like what Kate's team did at some point. In people whom LPs are not so easy, we may resort to neurosurgical intervention, either a lumbar drain or an EVD. If it's very difficult to keep poking these patients, if they have some bleeding risk for various reasons, and it may be easier to place a drain. But I do believe in regular LPs. I do believe in relieving pressure.
Sharon may well want to comment. Sharon, you might be.
It's a good point, Van Hock, and we don't have time to talk about raised intracranial pressure and all its challenges, but regular LPs are the first step before one turns to drains, which can get infected, or shunts. And the earlier you control the pressure, the better the outcome. And this has been clearly documented in HIV patients as well as non-HIV patients. There are some very, very good practice points in the upcoming ECMM global guidelines that Christina Chang and many of you here might have co-authored. I think it has been submitted and everyone has kind of seen a draft of it, but I would highly recommend that it be read, lunchtime, tea time.
Sunday afternoon.
Okay, I think it's 7 p.m. and
it's 9 p.m. Van Hock.
Oh, okay. Yes, okay, sure. Maybe
it's
thank
1
you
p.m.
very much to everyone for staying to the end. And thank you once again, Sharon, for bringing us together. Thank you to the presenters. And I think we can look forward to another session soon.
That will be in October, Van Hock.
Okay, if we could do it on a Wednesday, it would be perfect.
I think you're in charge of organizing that one. No,
okay.
I'm happy to help.
I'll do it.